My name is Eric Simpson, and I'm happy to speak to you today about systemic JAK inhibition for atopic dermatitis. I appreciate the IEC for inviting me. There's a lot of exciting news in JAK inhibition in atopic dermatitis. I've been a consultant and investigator for many of the companies that are developing JAK inhibitors, so just important for you to know. Okay, so here's the current landscape. Phototherapy, dupilumab, cyclosporin, other immunosuppressives for atopic dermatitis, moderate to severe. We'll be mainly talking about adults today. So do we need another drug? Do we need more drugs? Where is the gap that exists for, let's say, oral JAK inhibitors coming into the marketplace? Well, I would say the first gap is, dupilumab is a great drug. I have many patients on it. However, not everyone gets clear. I would love to have 100% clear, almost clear patients. And here you can see from the 16-week trial of Solo, about 38% get clear. So I think there's room for improvement in terms of more patients benefiting from a clear, almost clear skin. Same thing with EZ75. So I'd say we could push the efficacy more. Another gap, especially in dupilumab patients, are just the common side effects of conjunctivitis. So it'd be nice, 20 to 25% of my patients in clinic get conjunctivitis. That means I refer them to an ophthalmologist. So increased medical use and also just an annoying side effect that sometimes takes additional medications. And then you might have some rare side effects on your patient on dupilumab for many years. Some rare things can pop up and they're emerging as tens of thousands of people are getting treated. You might have the occasional patient who develops severe eye disease, super rare, or inflammatory arthritis, super rare, or facial dermatitis, also very rare. But for those patients, it might be nice to have another option as well. And so the other opportunity is that it's not just a type 2 disease, which is primarily, it's really important that it is centrally a type 2 disease, but there are other cytokines involved. And so possibly by inhibiting additional cytokines, you can have more people getting better. And there may be some phenotype, ethnicities, ages who have more type 1, type 17, IL-22, possibly than other phenotypes. So maybe we can capture more patients with an anti-inflammatory approach that's a little broader. And it's the JAK kinase, the Janus kinase signaling that allows us to be a little bit more broad. So as you can see here, these are all cytokines really important for atopic dermatitis, driving atopic dermatitis, and they're all driven by Janus kinases. They're signaling, and you can see if you blocked JAK1, you're going to hit them all, just about all of them. If you hit JAK2, you might get a couple more, and so you can kind of tailor your approach, your targeted approach to these various cytokines and disease states. Now, JAK1 gives you this nice panel of, if you block that. JAK2 gives you a couple additional cytokines, so maybe that could help. You add on IL-5, maybe some of the type 17 pathway with 12 and 23, mainly 23. But then you also capture some EPO, some erythropoietin, thrombopoietin, and GM-CSF signaling that could be negative if you dose it too high. Now, I'm not going to go over study design. Robert's already talked about that today. And so the study designs are pretty similar. There's a washout for topical corticosteroids, 4-week washout for systemics, 3 months for biologics. There's some variation, but I don't think clinically relevant when you look at the data. So 3-day washout for TCS for abrocitinib, 2 weeks for baricitinib. Maybe that's a little bit more difficult, and baricitinib maybe lost some people early on. But I'm going to talk about generalities because I don't have, in 10 minutes, I can only talk generalities with you. And so we're not going to go into a deep dive, just kind of my perspective of where we are in the JAK landscape. Inclusion are very similar. The patient populations are pretty darn similar. But the important thing to know is there's already 2 on the market for rheumatoid arthritis, baricitinib and upadacitinib, and they have black box warning for serious infections, malignancy, and thrombosis. So that's something that you have to think about and discuss with your patients because your patients are going to see this, all right? Upadacitinib, same thing, serious infection, cancer, thrombosis. Abrocitinib has a benefit. They're not on the marketplace yet, and so we don't know what their package insert is going to look like. Possibly could get a kind of class label just like the other ones. But don't be worried. I mean, we already use methotrexate, which has black box warnings of cancer and pneumonitis and hepatotoxicity. Look at the bottom one, potential fatal opportunistic infections. So you have to be a clinician, you have to manage risk, but you have to treat your patient. We still use methotrexate because patients need treatment of their chronic disease. It's going to be the same thing with JAK inhibition. They're going to need these therapies to treat their chronic disease, and you just deal with the risk and manage that responsibly. So let's quickly talk about efficacy and the benefit. Look, each JAK inhibitor has like 7 phase 3 trials. So I cannot go over all the different trials. And so what I'm going to do today is just talk about the flagship trials and the key primary endpoint of global assessment, clear, almost clear. And we're just going to look at that data set, those data points, and then I'm just going to make generalities that I think, my interpretation, knowing kind of a lot of the data. So the thing to take home is that baricitinib here has dose-response relationship, statistically significant proportion of patients getting clear, almost clear, at 16% and 13%, or 17 and 14, if you round up, that are clear, almost clear at the highest dose. Clinically relevant, statistically significant, and it's different. They're going to have 5 other studies. Some of them are a little higher, some of them are on the same. For example, the other Breeze study of 2 milligrams showed 24% clear, almost clear. So there's going to be some variability in there, but we're going to talk about trends. This is abrocitinib. This is a 12-week time point. Again, clear, almost clear. Their 2 studies show about 44 to 38 to 44% clear, almost clear. Dose response relationship. I'm going to be talking about the highest dose basically, but who knows? We don't know what the FDA is going to approve. We don't know if they're going to approve any of them, but these are just some generalities, just so you get an idea of what's going on in the JAK landscape. And then these are not published. These are just press releases at this point, but these are upadacitinib trials. All these are monotherapy, no topical steroids, and you can see dose-response relationship, really high percentages of patients getting clear, almost clear skin disease. They're all evaluated the same way. They're all non-responder imputation. So clinically relevant, all 3 drugs. Statistically significant, all 3 drugs. Maybe UPA's the strongest, with abro close behind. They're both JAK1 inhibitors, and then Breeze maybe slightly lower. Again, that's just a trend, but just something to think about. Now, this is a slide that's going to be for all the inhibitors. So I just put abrocitinib up here for no reason, because they're all similar. They reduce itch significantly. This is a 3-point reduction itch in the first 2 weeks, but they all reduce itch within days to 1 week. They can reduce significantly itch. Okay, so they're all going to be rapid itch reduction and rapid skin reduction, all 3. Now, if you look at a 4-point reduction, and so if you look at like the depth of the response, baricitinib, about 19 to 22%. This is only study 1 and 2. There's 5 other studies, but these, I think, puts it into some, I think it follows a trend, okay? 19 to 22%. This is monotherapy, no topical steroids, 4-point reduction at week 16. Abro, more in the 50s at week 12. And then upadacitinib more in the 60s, or low 60s at week 12. Proportion of patients achieving this pretty high hurdle of 4-point reduction. Oh yeah, I'm getting a news alert from our Central Command. Yep. All right. So it sounds like there's a abrocitinib just came hot off the press. They found that abro plus TCS is greater than just placebo and TCS. Okay, that's good, but not amazing. But they're starting to do comparisons. And the one comparison that was done in this study was abro at 2 weeks, the proportion of patients with a 4-point reduction itch versus dupilumab. So we're finally getting some comparative studies, not published yet, but it looks like at least at 2 weeks, abro is superior at the high dose, 200 milligrams, compared to dupi normal dosing. So that's exciting. I don't know what happens at week 12, week 16. Does dupi catch up? Who knows? I don't know the side effects. Just some breaking news I thought I'd share with you. Okay, last thing we're going to talk about is side effects. I'm only picking 1 study, lots of caveats. There's 6 other studies for each drug I haven't talked about. There's no way I can present it all, but I'm going to just make generalizations. looking at total adverse events across the board of just one study, the flagship study, okay, for each drug. Barely increased AEs in general compared to placebo for baricitinib. A little bit more in abro high dose and UPA high dose in this one study versus placebo, but they're mainly tolerability problems. So I would say I'm not too concerned about overall AEs, and more importantly, AEs leading to treatment discontinuation. Look at baricitinib on your left. There's more in the placebo. Look at abro. There's more in placebo. And then UPA, a little bit higher than placebo, but still not alarming AEs leading to treatment discontinuation. What about SAEs? Again, look at the trend. This is just one study, but it's consistent across the studies. There may be slight differences of 1% here, 2% there. The companies are going to be arguing in marketing, 1% difference. Clinical relevance, I think, low SAEs across the board. Baricitinib lower than placebo, abro lower than placebo, UPA same as placebo. Very reassuring as a clinician. Nausea, some slight differences. Baricitinib doesn't seem to be a problem at the higher dose, whereas you do see some nausea with abrocitinib and upadacitinib compared to placebo. Again, though, these are mild to moderate. They don't really lead to treatment discontinuation, but there is a difference between the drugs there. And then headaches, there's a slight elevation over placebo across the board. Probably more so in the abro and UPA groups, but again, mild to moderate, don't really lead to treatment discontinuation. Acne, some differentiation, not much in bari, not too much in abro, but you're starting to see a little bit of an acne signal, again, mild to moderate in the UPA group compared to placebo. And then just very rare zoster cases and some slight increases in herpes simplex, but not eczema herpeticum. So other side effects to think about, herpes zoster slightly increased over placebo for all of them. CPK elevation is not very common. Is very common, but not clinically relevant. You'll see some lab abnormalities. Labs will be needed for all of them. We don't have time to talk about the exact issues there. Rare pulmonary embolus. One's happened in abrocitinib phase 2. One's happened in a bari phase 3, and I don't know the rest. There's long-term studies that haven't been published yet. So that's going to be something that we have to understand and risk stratify as a clinician. Infection, cancer are both theoretical risks. So in summary, all 3 oral JAKs in phase 3 can clear skin within weeks. They all reduce itch within days. Bari's probably more modest in efficacy. Looking at, we won't know really unless you do head-to-heads, but just looking at all the data, it's probably more modest, but possibly more well tolerated, not as much nausea and headache. Abro and UPA have very high efficacy, but at the price of some mild nausea, headache, acne. Lab monitoring will likely be required. Integrated safety studies, long-term extensions, and registries such as Treat, Target, Corona, that's going to be where the gold is. That'll be vital to our understanding of the long-term risks and understand the risk-benefit ratio. So how do we best counsel for rare, serious risk? That's going to be up to us as clinicians. And maybe zoster vaccines risk stratification for thrombosis may be important. So thank you so much for your attention.